Good afternoon, everybody. Thank you so much for joining us. I know it's been a minute since we've hosted one of our education series webinars. It's been a busy summer for everybody, but we have had some changes, and Rochelle's going to be with us today to talk about it. So I am Molly Brown from the Heartland Telehealth Resource Center. We're glad you're joining us today for the education series focused on telehealth billing, coding, and policy. Just a few notes as reminders. This session is being recorded and we'll share it with you afterwards. You can also find them on our YouTube channel. I will be dropping some of that information in the chat during the presentation. Your microphones have been muted. Please unmute or use the chat to talk today. We do have a pretty big group today, so it might be easier to use the chat, and I will monitor that throughout the presentation. If you would like a completion certificate, please contact us at our email, htrc@kumc.edu. I will also put our email address in the chat later. So let's get started. I'd like to introduce Rochelle Marting. Rochelle is a local attorney who is also a registered health information administrator and certified medical coder. Her practice focuses on medical coding, billing, and reimbursement, HIPAA privacy and security, health information management, and regulatory compliance. We're thrilled to have Rochelle with us today to talk about the 2024 physician fee schedule, as well as guidance on the short-term future of telehealth billing and payments. Now I will turn it over to Rochelle.
Hey, thanks, Molly. It feels so weird to be saying 2024 rules coming up. I'm still getting used to that. But the Medicare proposed rule came out in July. And again, these are just proposals at this time. It gives us a fairly good sense of what we could be looking at for changes and policy that would take effect January 1. But nothing in today's session has been finalized yet. Actually, the comment period is still open. So if through our information and discussion today, you think of any questions you would want to ask to CMS about some of the details of these policy changes or provide input, I'll give you some information in just a minute on where you can submit those for the next couple of weeks. We then would likely see a final rule laying out the final policies, and I'm sure through HTRC we will provide you those updates. Usually mid to late October is when we would see those. The intent is for CMS is to have those published 60 days in advance of when the changes take place, January 1. They've been running a little bit behind the last couple of years, but that's typically when we would see it. In the proposed rule for 2024, of course, telehealth has a huge presence in the proposed rule. Things that are going to be changing just in light of the public health emergency ending this year and some federal legislation at the end of last year. We'll talk about what today's status is and what some of those proposals are for next year. Just a little bit of information about remote patient monitoring services. And when I use remote patient monitoring, I'm kind of using that term broadly to mean both remote patient monitoring and remote therapeutic monitoring. Similar services, different sets of codes, but we'll talk about some of those changes in just a little bit. Those of you working with both physicians and non-physician practitioners, like nurse practitioners or physician assistants, may be interested in some of the guidance about split and shared billing that came out. I guess it has been in effect in 2023, and there are some proposals on how that might look for 2024 as well, really surrounding which of those professionals gets to attach their name to the claim, which in turn dictates the amount of payment that you get for the services. Now, one area that I think is really interesting, I'll spend a little bit of time on, and we can certainly do a deeper dive into it if it's of interest to the group, are new codes and new payment for different social determinants of health services, and a principle. It's a navigator for certain diseases to kind of manage high complexity diseases that really need a specialized navigator for a patient. We'll kind of talk about some of those new services coming up that likely would get finalized and be available to bill and receive payment for beginning January 1. So I want to start just briefly about the proposed rule If you are interested in reading it, we were actually very lucky this year. It was a short 963 pages instead of the typical 1700. So it's much shorter if you want to go in and read it yourself. But for some of the topics we're talking about today, if you have questions, if you want to submit comments, questions, feedback for CMS to consider. The deadline for commenting is September 11th at 5 p.m. And the way you would do that is go to regulations.gov. There's a search bar at that website, and you can search for this proposed rule number. So you can just type in CMS 1784. You could type in physician fee schedule 2024, but the box that you see on their screen, here, this is sort of the search result that you would be looking for. And if you have comments you want to make, they make it nice and easy. There's a little comment box here. You can do this anonymously. So if you're working for an organization that may not necessarily want you submitting comments on their behalf, and just as an individual, you want to submit those comments, you can do that. You can literally type a comment in a comment box, kind of like sending an email, or you can write it out in some more formal letter format and attach it. So lots of options to submit your comments. Just make sure if you have them to get them in by September 11th if you want to have them considered. There's another important date coming up that I want everybody to keep in mind for telehealth specifically. Just so we don't miss it, I feel like we're always talking about this in February or March with HTRC. But one of the things that is considered and published in the proposed and final rulemaking this time of year for the upcoming calendar year is what services could be added to the list of covered telehealth services for the next year. And those decisions come from public requests. So if you have a service that you provide, maybe that has fallen off the list as a result of the PHE ending, or a service that wasn't on the list before that you would like considered, the deadline to submit those requests is February 10th of this upcoming year. You submit your requests, and then they will be considered, and they will be issued potentially in the proposed rule next year in 24 to potentially take effect January 1st of 2025. Now, the things that I'm always seeing in the proposed and final rule when CMS is looking at requests to add services to the list of covered telehealth services, to keep in mind, if you want to do this, CMS is looking for data, how the service is comparable to something like an office visit or another inpatient in-person service that can be done virtually through telehealth. It has to meet the definition of a telehealth service, so something that can be live two-way communication. Remote patient monitoring, because it's not a live audiovisual two-way communication, is a covered service, but it's not a telehealth service under these rules. And then CMS is always indicating they didn't have enough data to approve a request, or enough data that a particular service remains safe and effective in a telehealth format. So all of that information, rather than saying, please consider code 12345, would be extremely helpful if you've got a service that you want CMS to consider adding to that list for next year. So I've got the website, and we'll send these slides out afterwards. If you would like to submit a request, where you can go on the CMS website, there's lots of ways that you can do it. You can mail, you can fax. Probably the easiest is an email address that you can send a quick email to with your information about your request to add or have CMS consider new telehealth services. All right, so I'll dive right into some of the telehealth policy changes potentially for this upcoming year. So one of the things that's really important that has been really a question mark in my mind all of 2023 as the PHE got renewed once or twice before it finally was allowed to expire. Last year, we had a decision, we had a piece of legislation in, I want to say March of 2023, that said many of the flexibilities for telehealth that have been put in place as a result of the COVID PHE must, because it's federal legislation, must remain in effect for at least 151 days after the public health emergency ends. That was last year. We end up going through all of 2022. Let's see if I can get my years straight here. 2022. At the end of 2022, but after all of the final rules for 2023 had already been decided by Medicare, we had another piece of federal legislation covering the same topic on telehealth, but instead of 151 days after the PHE ends, it mandated that those same flexibilities remain in effect for Medicare through December 31st of 2024. At that time, then, we had kind of an incongruency in policy. We had a statute saying certain things need to remain in place through 2024. We had a CMS policy saying 151 days after the PHE ends. So this proposed rule closes that gap and confirms that CMS will follow Congress's mandate and make certain flexibilities for telehealth available through December 31st of 2024. Now, I told you that we would typically see a final rule come out in mid to late October for the next year. Under our current policy that was finalized last year from CMS in the physician fee schedule, that 151-day timeframe is still in effect. That takes us, since the PHE ended May 12th, 151 days from that date is October 10th. What I don't know yet is if we will have a final rule from CMS by that date to confirm the extension of these flexibilities through December 31st of 2024. That's a lot of technicalities, but I don't anticipate CMS would leave a gap in those flexibilities before the final rule is published. So we may either see this rule come out sooner than it has been in the last few years, or we may see an interim rule from CMS to kind of close that gap until this new 2024 final rule takes effect. It's a lot of legalese, but I think important to understand that we're not quite in the clear yet between October and January 1. Those flexibilities that are implicated by what was 151 days after the PHE ends, what now is mandated by Congress, and I see no reason why CMS wouldn't finalize these rules. The pieces of the flexibilities that are going to be extended through the end of next year are RHCs and FQHCs serving as eligible distant site providers of telehealth. I know it's been, 3.5 years since the PHE started, amazingly. But prior to that, if you can think back to prior to 2020, RHCs and FQHCs could always serve as the originating site, the place where the patient presented for the telehealth service, and a distant site provider somewhere else rendered the service and billed for the distant site professional services. But prior to the PHE, RHCs and FQHCs could not themselves bill as a distant site provider of telehealth services. During the PHE, because the flexibility in where the patient is located extended or opened up to include the patient's home, RHCs and FQHCs were added as eligible providers, eligible Medicare participating providers, to bill for distant site services so they could render a telehealth service to one of their patients at home and be able to bill for that RHC or that FQHC visit. During the PHE, that flexibility to open up the eligible locations where the patient is located, it used to be restricted to a clinic, a community mental health center, an RHC, an FQHC, a hospital, a critical access hospital, and so on, medical sites. During the PHE, CMS allowed the patient's home to be an eligible location where the patient could be situated while a distant site provider renders telehealth. When that was the case, there was no healthcare provider typically billing for the originating site. It was just the distant site provider billing. And I say typically because there were some circumstances that hospitals under the Hospitals Without Walls program could have made patients home an outpatient department of the hospital to bill potentially the originating site and the distant site fee. Now that we're outside of the public health emergency, the patient's home as an eligible site has actually been expanded since May 12th, even broader than what it had been during the PHE. During the PHE, the patient's home was added as an eligible site. Now that the PHE has ended and through they're proposing through the end of December, I fully anticipate that will be finalized because Congress mandated it. Anywhere the patient is located in the US can be an eligible originating site. That's not limited to a home. That can be the grocery store parking lot. That can be a library. That can be a school for Medicare. It could be an eligible originating site. So it's broader. Now I say that, I will say that with a caveat, with a big asterisk. That is only a payment rule for Medicare that says we would pay in those circumstances. Providers rendering the telehealth service need to keep in mind that licensing rules will still apply under state law. And most states are still requiring that the provider be licensed in the state where the patient is located at the time of service in order to render a telehealth service. Otherwise, risking the unauthorized practice of medicine in the state where the patient's located at the time of service. So this is a payment rule. This isn't a licensing rule. That also means when a visit's being scheduled or the service is being initiated, we need to know where the patient is located. I've scheduled some telehealth visits myself, and I've seen a lot of different scheduling mechanisms that I really like. And one of those asked me to confirm, will you be in the state of Kansas at the time of your service? Or choose, where you will be located. Is it your home? That selection is translating to the site of service documentation for my note, but also confirming the provider who sees me is licensed in the state where I will be situated when that telehealth service occurs. Excuse me. The other big requirement that has gained a lot of attention in the last 2 years, yet has never actually taken effect because of flexibilities during the public health emergency, is the requirement under federal laws a few years ago that a patient who would begin to have telehealth services for mental or behavioral health without co-occurring substance use disorder and that would not otherwise be covered under telehealth rules, when all those things apply, would have to have an initial in-person face-to-face visit with a provider before that telehealth service for mental behavioral health can begin. So this was following the Support Act, which kind of expanded coverage for patients with substance use disorder or co-occurring mental behavioral health conditions to be able to receive their services at home. Those do not require an initial in-person visit. They didn't before COVID, they didn't during, and they will not after. The very limited circumstance when it could have come into effect, but it has not yet, is when the patient does not have a co-occurring substance use disorder, along with mental or behavioral health diagnoses, and the service is not otherwise covered as telehealth. So that typically would mean if the patient was at home, outside all of our COVID flexibilities. But because patients can be at home right now, that service is just a normal covered telehealth service. There is no initial in-person visit requirement yet. That was mandated to be extended at least 151 days after the PHE ends last year. CMS followed that rule and extended it. Then Congress also mandated that flexibility remain in effect at least through December 31st of 2024. This is not a flexibility that CMS next year can eliminate or extend on its own. Because it's based in a federal law, it's going to take a literal act of Congress to make that change, eliminating the requirement. I say that though, there are a lot of telehealth bills out there that would address a lot of these flexibilities or extensions after the end of next year. And this is one that I consistently see on the bills that are being introduced to potentially be made, how do I say this, eliminated from the federal law, which means it's a flexibility that we would eliminate permanently.
Rochelle, since it's
Yes.
probably related, I do have a question in the chat. I know typically
Yeah.
we like to wait
Yeah.
towards the end, but we usually have to go back and remind ourselves of the information.
Sure.
Can you speak to cross-state telehealth? Provider's home is in one state and the patient in another state in which the provider is also licensed.
Okay, so the provide, let me make sure I understand the question. The location from where the professional is rendering a service is their home, their home residence potentially. The provider is rendering a telehealth service to a patient located in another state, and the provider is located in that other state.
From where, Monica, would you like to ask? The second part of that is Medicare is not allowing us to add the home address in the non-home state.
Address in the non-home state. That's correct, because there's kind of two parts to this. One piece, I think that is it Monica who asked the question, might be referring to when the PHE ended. There was a flexibility also that we didn't have to enroll providers' home addresses during the PHE if that's where they were rendering their services from. The service location, kind of picturing a paper 1500 claim form down in box 32 and 33, the service location, the billing provider address. Those would be the clinic location that the provider normally sees the patient from. When the PHE ended, the requirement to enroll a practice location in section 4 of your 855 enrollment form was renewed, was again a requirement if that's a regular practice location, not a one-off, maybe on a day that the provider's sick, but regularly they're rendering services from that location, needs to be enrolled as a practice location with Medicare. However, because the provider is billing the distant site service, it's their location that gets enrolled as the practice setting, not the patient's address or where the patient is located.
Oh, okay. This is Monica. Can you hear me?
Yes, barely, but I can hear you.
Yeah,
Hi.
Monica, Donna. Oops, excuse me. My microphone was up. Sorry.
There you go.
Hi.
Sure.
This is Monica Donofrio from BCS. So that's been a little bit of a problem for us if our provider is rendering and they're in Michigan and they're rendering in Wisconsin or Ohio or Minnesota. We've had difficulty in that state to add their home address as the provider location. But you're saying that we would add our address of, like, for example, we have offices in those states. We would add that state's address.
Well, the service location is Michigan, right? Where if that's the
Yes.
provider's home state.
Yes.
So one of the things I'm picking up on, you might be asking, is Wisconsin and those other states, if they're a different locality jurisdiction under the Medicare administrative contractor. Is that part of the question? So enrolling
Yes.
in the different locality where the patient's located. So when the professional is billing, they only need to have the practice location, that Michigan, in this case, practice
Right.
location enrolled with the locality, with the MAC for Michigan. That's where the claim's going to go. The patient's address won't get on the claim as a billing location or a service location for those distant site services.
I don't know that I understand.
Okay.
So, all right. So I
there
have.
doesn't need to be an enrollment
So we're
of the
trying.
providers. Go ahead.
Okay. Well, I'm sorry. We're trying right now to add the provider's home address to each state that he is licensed in and provides, I would say not frequent but ongoing telehealth services in those states. So the states are not accepting a home address that's not in their state.
Yeah. And this may meet your MAC provider enrollment may be able to help you with this. I'll tell you how
Okay.
it works in our particular jurisdiction, our particular MAC and locality. If Dr. Marting is located in Kansas City, Missouri, and that's where Dr. Marting, that's where my home is, that's where I'm going to render all of my telehealth services of folks who live in Illinois, Iowa, Nebraska, and Kansas.
Yes.
But I'm located in Kansas City, Missouri. At all times, I'm rendering those services.
Yes.
My 855 practice location would get filed with the MAC and the jurisdiction for Kansas City, Missouri only. I wouldn't go to the Kansas MAC and register my practice location there, or Iowa, or Nebraska, whatever state.
Okay.
It's just because when you bill out, you're billing to, in my case, Kansas City, Missouri, in your case, Michigan. You're
Yes.
billing to that MAC, that's the service location.
Okay.
Provider needs to be licensed in those states where the patient
Yes.
is, but does not have to submit, at least this is how it works in my jurisdiction, does not have to submit an enrollment for practice locations in those separate jurisdictions.
Thank you very much. I understand it.
Yeah. Connect with me offline if you've got other questions on that through the HTRC. But that's typically how that works, because really when your claim goes through for Michigan or Kansas City, Missouri, as the distance site, that's the locality and that's the fee schedule you will be paid under.
Yes. Yes. Okay.
And that's really what the enrollment is intended to collect and make sure enrolled in the payment locality.
Okay. Thanks, Rochelle. Appreciate that.
You're very welcome. Absolutely.
And for the greater, our large group, I am documenting every question in the chat box. So if we don't get to them, we typically can address them in our follow-up emails, and then can handle any one-on-one questions you may have after. So just keep your eye on the chat box too, and I'll be putting in our contact information.
Absolutely. We had guidance last year in the Medicare physician fee schedule about place of service coding for telehealth. Through the public health emergency, instead of using a place of service 02, which just says it's a telehealth service, we use the place of service where the visit would have been rendered had it been in person and face-to-face. So if you're a provider office, that might be place of service 11, or a nursing facility, or a hospital inpatient, whatever that place of service would have been. The reason for that, I guess you could have continued to bill 02, but if you used the place of service that would have been reported for an in-person visit, you had the potential to collect the higher non-facility rate for that service. Place of service 02, a telehealth service rendered to a patient other than the patient's home, is paid at the facility rate, which is a little bit lower than the non-facility rate. And the idea is if the patient's in a facility setting, the distant site provider at another location isn't incurring all of that practice expense and overhead where the patient is, the same way they would in a non-facility setting like a provider office, where the provider is incurring all of those practice expenses. So that rate's a little bit higher. Last year, early last year, the telehealth place of service code 02 was split out into two. 02, our old telehealth place of service still exists, but now it's reported for a telehealth visit for an individual located anywhere but the patient's home at the time of service. And this is for the distant site provider to report. Place of service 10 is a telehealth service rendered to a patient in their home. And last year in the Medicare physician fee schedule, Medicare said once the PHE is over, once we again start reporting those telehealth place of service codes, they would be paid at the lower lower facility rate again, just like they were prior to the public health emergency. But we had new guidance this year that's going to be helpful for those of you who may be billing telehealth for patients who are at home at the time of service, and that place of service 10, telehealth rendered to a patient at home, would under this proposal be paid at the higher non-facility rate, just like place of service 11, a provider's office would be. The other extension that was in place for 151 days after the PHE ends, now mandated by Congress, so I anticipate this will be finalized by CMS as well. Those services that during the PHE were allowed to be rendered using audio only rather than live two-way audio visual and interactive communication technology will still be allowed to be rendered as audio only services through the end of next year. I think in one of our sessions earlier this year, we talked about some congressional hearings on telehealth, and I listened to one of those hearings because this is what I do on the evenings and weekends, I guess. But it was really interesting to hear Congress talking about how they got to this decision to extend certain items for 151 days now through the end of next year. There was what I felt was a willingness to consider making the items on this slide permanent. But Congress wasn't ready yet to change the Social Security Act because they wanted more data on program integrity. They wanted more data on patient safety before they took that type of measure to make them permanent. So I think the items on this slide that we're seeing, they're right up there. They're primed for potentially being made permanent. This extension through next year gives Congress that time to collect program integrity data, put safeguards in place, and evaluate the safety to potentially move forward with making some of these permanent flexibilities. No guarantees, of course, but that's sort of the tone of the congressional hearings. We had different categories of telehealth services. We had our usual permanently covered telehealth services. They were there before the PHE. They will be there after the PHE. Then we had these two kind of confusing buckets of temporary codes. One was called temporary, one was called category 3. In my mind, they were both temporary, but they meant different things. True let me back up. Services that were categorized with the title, quote unquote, temporary, they would go away, or went away rather, the day that the PHE ended, May 12th. There's this other bucket of services that were designated as category 3 telehealth services that would remain in effect through the end of this calendar year. And so last year, several of the therapy codes were moved from temporary, that would have gone away on May 12th, to category 3, where they're now available through the end of this calendar year. Now, this is the thing I want to highlight, though. So these are the things that moved into this category 3. They will be available through the end of 2023, at least. A lot of these deal with the therapy disciplines. So if I come down to, what is it? On the right-hand side, we have therapeutic procedures, different speech, physical and occupational therapy services that are part of category 3 that will be here through the end of the year. There is a disconnect between the codes and how long they will be covered and when the distance site providers can render those services. So speech, physical therapy, and occupational therapy will also continue to be eligible distance site providers through the end of 2024. But the codes they use may fall off the covered telehealth list at the end of this year. So it's a little bit misleading, and something we'll have to keep an eye on, both through policy and potential legislation from the federal level. Now, a couple I want to highlight that are coming off or did come off of the telehealth list when the PHE ended. Inpatient initial hospital care coming off the list. Hospital discharge services coming off the list. Initial observation care over here coming off the list of eligible telehealth services. Now, frequency limits has been a telehealth topic for the last several years in the Medicare physician fee schedule, both proposed and final rules. There's really two areas where this has been the biggest focus and the biggest emphasis for both providers and CMS. One is the frequency at which an inpatient service can be rendered as a telehealth service. So your daily visits with patients in the inpatient setting. During the public health emergency, that frequency was eliminated, really trying to help reduce exposure when it was appropriate to do so. It always has to be medically appropriate to do it via telehealth. Excuse me. So those rounds from the hospitalist could be done via telehealth throughout the patient's stay. In the nursing facility setting, prior to the PHE, subsequent nursing facility visits could only be done once every 30 days. Last year, Medicare proposed to reduce that down and consider, do we make it once every 3 days, which is what inpatient services used to be prior to the PHE, or do we do something different with it? The frequency limit for follow-up subsequent nursing facility visits last year was reduced from 30 days to once every 14 days. They didn't go so far as to match the every 3-day limit that hospital inpatient services would have. But now in this proposed rule, only a year later, Medicare is considering, is proposing, proposed rule only at this point, to eliminate those frequency limitations entirely on a permanent basis, both for subsequent hospital inpatient and observation, as well as subsequent nursing facility visits. Excuse me. During the public health emergency, the supervision of telehealth services had some flexibilities as well. Normally, if we're in a traditional clinic setting and we have a nurse or other clinical personnel who are providing services to the patient and being billed under a nurse practitioner or a physician's name and number, that's being done through a billing mechanism called incident to. That nurse's service is incident to a provider's professional plan of care. Provider initiated the plan, nurse is carrying it out. Part of that incident to billing mechanism requires that at the time that the clinical staff is rendering the service, there is direct supervision by a provider. It doesn't have to be the ordering provider or the provider who initiated the plan of care, but there must be direct supervision by the provider whose name goes on that incident to claim. And during the public health emergency, we had folks working from home. We had lots of different models that were coming out. And to maintain this statutory requirement of incident to, CMS came up with a concept called virtual presence, where as long as that supervising provider was able to virtually intervene during the telehealth service, that would meet the requirement for direct supervision. Now, last year, CMS said December, at the end of the calendar year in which the PHE ends. So that would be December 31st of this year. Last year, Medicare said that rule goes away. This option for virtual presence goes away even for telehealth, which means the supervising provider, the one rendering direct supervision in the office suite and immediately available, and the person actually rendering the service, they have to be in the same physical location if virtual presence were to go away. So in this proposed rule, Medicare is saying that they would continue this concept of virtual presence through the end of next year as well. And kind of hinted that they are considering, they're looking at making it permanent. Now that is probably not something we're going to see finalized this year, but it kind of hints at maybe something great to comment on if your organization has relied on it. Something that we're likely to see in a proposed and final rule next year in 2024 to take effect on a permanent basis beginning 25. They address this in the concept of teaching physicians as well, because teaching physicians have to be present for a key portion of the service. And that used to mean the history or the exam or the medical decision-making was a key component, was a key portion of the service. Through the PHE, that rule was relaxed as well, so that the teaching physician could have virtual presence in a telehealth session to meet that requirement. Now, that is going to continue, but CMS emphasized that virtual presence when it comes to teaching physicians means it requires real-time observation, not just availability, like incident to virtual presence requires, in order to meet that requirement. And it cannot be audio only, it has to be audio visual technology for teaching physicians. Was there a question in the comments, Molly? I saw you come back on.
Yes, but I think I messaged them and said, we can get through your slides and then we can ask.
Okay, yeah, sure. Now, originating site fees, no one's going to get rich off of billing originating site, but this was one of the biggest increases year over year that we've ever had in the originating site fee, and it went up $1.30. It's still in the, I should have gotten the exact number, $20 to $30 range for an originating site visit, but that's on the way. So for remote patient monitoring, there were some clarifications in the proposed rule that Medicare is considering finalizing. I think these probably will get finalized, maybe with some clarifications based on commenters who are rendering monitoring or therapeutic monitoring services. If you're doing this, pay attention to this section in the rule and consider submitting your comments or feedbacks or any scenarios that may not be clearly addressed in the proposed rule that CMS may need to clarify. And CMS says only one practitioner, only one individual professional can bill for remote therapeutic monitoring, for remote patient monitoring. And RPM, those are the codes that come in, that are in the evaluation and management section that are typically billed by physicians or qualified health professionals. The RPM services can be furnished during the global period of surgery. They are considered separate from the global surgical package. And the same for RTM. However, a practitioner could not bill both RPM and RTM in the global period after surgery. Depending on the procedure, that may be anywhere from 10 to 90 days for Medicare. Now, I mentioned split shared billing rules. So incident 2 is a concept in non-facility settings, like the provider office, that allows a physician to bill for a service rendered by a nurse practitioner or rendered by other clinical staff when all of the criteria are met, so that the service is paid at the physician fee schedule rate rather than a lower rate of payment for a nurse practitioner or PA of 85% of the fee schedule. Split shared service is a facility billing concept. It's most common in the hospital setting. And split shared means on a single calendar day, both a non-physician practitioner and a physician share an evaluation and management service. One may see the patient in the morning, one may round on the patient in the afternoon, but because they're in the same provider group, same specialty, they're sharing a service. And when certain requirements are met, that shared service could be billed under the physician's name rather than the nurse practitioner or PA, to be paid at the higher 100% of the fee schedule rate rather than 85%. Those criteria prior to COVID, there was a concept called the substantive portion. Doc has to render a substantive portion of the split or shared visit, which of course my attorney mind, my policy reading mind would say, what does it mean to be a substantive? Is it more than half? Is it a considerable amount? Is it a preponderance? Is it nearly all? Where on the spectrum does substantive fall? And in the manuals before COVID, the Medicare manual said substantive means a key component. They have to render a history, they have to render an exam, or they have to provide the decision-making for the visit. That was a substantive portion. But the coding rules changed. And when the coding rules changed this year, effective January 1, impacting facility services where the split shared billing concept is used, that definition of substantive portion wasn't going to apply anymore, wasn't going to work, because we no longer select our levels of service based on history, exam, and decision-making. Now it's decision-making or time. So for a period for the 2023 year, CMS said, we'll kind of give you this transition year. And in this transition year, substantive portion could mean either the physician renders the medical decision-making component, or more than 50% of the total time of that shared service. But providers, be ready for January 1 of 2024, because at that time, medical decision-making will not be a consideration, and it will exclusively be time. Providers have been trying to get prepared for that this year. And in the proposed rule, CMS said, we are thinking about maybe extending that one more year, which would mean through the end of 2024, in a split shared visit scenario, providers could still potentially bill under the physician name and number if the physician renders a substantive portion, either the medical decision-making component or greater than 50% of the time. CMS is hinting at, although I hate to try to predict what the agency will do, but hinting at maybe this will remain the way substantive portion is defined indefinitely. However, what it would mean if it goes away at the end of next year, and the only way to bill for a physician service in a split shared scenario is time, it would mean that essentially every single visit needs to have time documented. Because if the nurse practitioner rounds in the morning and doc comes in later, if nurse practitioner has not documented his or her time for the visit, there is no way to determine that doc rendered greater than 50% of the time. And that's going to be a big change in documentation for providers. The other thing that would mean from my vantage point, if that were to go into effect and time becomes the exclusive determination of whether a split or shared visit can be billed, is that providers will need education on what they can count towards their time. It's different than it used to be. It used to be just unit or floor time dedicated to that individual patient. Now, the types of activities are much broader that can count towards time. And we want to make sure both providers know what they can count towards their time to determine who bills for the visit. Okay, I want to talk briefly about a couple of services that are in the proposed rule to potentially be added as new benefits with their own codes that might get paid. And I anticipate these probably will go into effect, but just some of the caveats, some of the requirements might vary a little bit in the final rule. One of them is a social determinants of health service. And this can be reported in addition to an evaluation and management service, and it can be reported once every 6 months. And the social determinants of health service requires using a standard evidence-based tool. They don't dictate use of any particular tool, but they do give a website that will have the links when we send the slides out, where you can say, where CMS is saying this is a list of examples. So it would be maybe a good idea to look at those specific examples and what tool makes the most sense for your practice type, your providers, and your patients. So use a standard evidence-based tool to collect social determinant of health information. Using this tool, they anticipate it would take about 5 to 15 minutes of time to collect the information, to consider it in the decision-making and how you carry out care for the patient. Now, one of the things several things I think are interesting about this service. At the end of the assessment, you might learn things about the patient you didn't know before. You might learn they're not taking their their full prescribed dose of medication for financial reasons. You might learn that they're homeless. You might learn that they have other social limits on that may impact their access to care. There are diagnosis codes, there's Z codes in kind of the status or informational code section that address different types of social determinants of health, like patient noncompliance with medications due to financial reasons. There are codes for that. And in the proposed rule, CMS expects that when you have findings from this standard evidence-based SDOH assessment, that you will add any applicable diagnosis codes to that patient's claim. So I'm kind of foreseeing there's some data collection implications that CMS might be considering because they want to know what those SDOH limitations are and potentially look at the impact on health outcomes that they can only do when they have the data. Now, for today's session, one of the important implications is that CMS is proposing that this would be added to the telehealth list of services that could be rendered via telehealth. Principal illness navigation, or PIN, as you'll see it referred to in the proposed rule, PIN services are really designed to take a patient with a single very complex condition, so cancer, for example, and really help the patient navigate the health system, the social resources for that diagnosis. So typically you would have an initiating visit. The principal illness navigator would have an initiating visit about that condition. It could be one serious condition, something that's expected to last 3 months or more, and meets these criteria. Cancer, COPD, congestive heart failure, severe mental illness, substance use disorder are just examples. They're not an all-inclusive list of limitations. So this initiating visit, one piece, again, if this is sparking your interest as something you could potentially provide, a question mark I had in my head is the language around who renders the initiating visit and who carries out the navigation services. The initiating visit, CMS said, would be an E&M service by the practitioner who would be billing for the principal illness navigation. That concept has come up in other settings like our mental behavioral telehealth services. And if they required an initiating in-person visit, could it be another provider in the same group practice who saw the patient in person versus the one rendering telehealth? So when I see the practitioner, I always wonder, does Medicare mean or another provider of the same specialty in the same group practice because they bill and receive payment as if they're the same individual, or do they truly mean the exact same individual must have the initiating visit and bill for the PIN services? Medicare would not typically expect, although the proposed rule doesn't say they would prohibit it, but doesn't typically expect that hospital services or ED visits or skilled nursing home visits would typically be the principal illness navigation initiating visit. So they're thinking this probably is more of a consultation or office setting type service. Although if you can see other scenarios, those would be great to submit for questions and comments. After that initiating visit, that principal illness navigation visit, after that, the services are carried out incident 2, which right now, through the end of next year, if these rules are finalized, would allow virtual presence to meet the direct supervision requirement of incident 2. But if that flexibility were to go away at the end of next year, that would mean the principal illness navigation services to bill for them must be rendered by a professional physically situated in the same office suite where the billing provider is located. So here's just an example of what CMS sees as included in this principal illness navigation benefit. It's billed on a monthly basis. 60 calendar minutes per month. What I anticipate, questions I would anticipate getting asked and clarification in the final rule is whether 60 minutes is a minimum threshold. When they say 60, do they mean 60? Or does the midpoint rule apply? Where as long as we pass the midpoint and have 31 minutes in a calendar month, could this be reported? That question will remain to be seen when the rule's finalized. But it includes a person-centered assessment, and with the goal of understanding the patient's story, needs, goals, preference with this condition, tailored support, goal setting that's patient-driven, education, coordinating care transitions, building patient self-advocacy. When I look at those requirements and I see coordination of care transitions, what I didn't see in the proposed rule is a discussion of whether principal illness navigation could be reported in the same month as transitional care management services. I anticipate that's something commenters may ask that we may see as clarification in the final rule as well. Even more services, but this is all really just kind of coordinating anything and everything the patient needs, from medical needs, care transition needs, social support services for this severe illness. And with 2 minutes to spare, I can take questions.
Thank you, Rochelle. As a quick reminder, because some of you may need to hop off if we don't finish right at the top of the hour, you can email us at HTRC and kumc.edu for any questions, and if you would like a certificate of attendance. We will be providing answers to the questions in the chat in our follow-up email as well. So if you do need to hop off as we get to these questions, you can contact us in that way, and keep your eyes open for the follow-up email in the next couple of days. The next question we had is regarding the O2 code for place of service. We are still using 02 place of service. Are you saying that we should not be doing that? If so, what was the day that would be no longer be doing this? When should we stop?
So as well, O2 can still be used, and it could have been used through the PHE as well. It was never prohibited. The flexibility during the PHE allowed you to bill a non-facility place of service code like 11 to get the non-facility rate of payment. So if you've continued to use O2 for a telehealth service rendered to a patient other than the patient's home, because home is 10, you're just getting the facility rate of payment, which might be a little bit less if otherwise you could have been doing it in the office setting. So that's still available. You're probably getting paid for those same claims. But if you wanted for a little bit of extra time, if it's financially worth it, you could have reported like place of service 11 instead of O2.
The last question was, and this was in reference to the social determinants of health codes and then the principal illness navigation, is do you anticipate these billing opportunities be added to the FQHC, RHC qualified visits lists? Do you see any time in the near future that the qualified visits list will be updated with new changes post PHE?
Yeah, that's a great question. I'll go back and confirm in the proposed rule if the new SDOH and principal illness navigation code were suggested to be added. I don't think they were. And because remote patient monitoring hasn't been added yet either as a separately payable visit. So let me double check that and look. It certainly seems like this is the right time to reconsider what might be separate from those all-inclusive rates or those per visit rates. But Medicare's just been really hesitant to do that with some of these new benefits so far.
Okay, thank you. I did note those questions, and like I said, we will be getting some clarification on the last question and get that sent out. You'll receive a link to this video as well, and be on the lookout. It seems like we may need to pull something together for the new codes, so I think that might be a really good webinar, and we may incorporate it into maybe a Q&A that can be helpful following this webinar. It was a lot of information today. So please contact us with any questions that you may have, and we will be sending out a date for our next upcoming webinar in September. So be on the lookout for that. Anyway, thank you so much, Rochelle, as usual, and everyone enjoy the rest of your week, and we'll be in touch soon.